Welcome. I'm going to be talking about, the title of the talk is adequately vague, which allows me to talk about pretty much anything I want. So my name is Kamran Aslam. I'm a electrophysiologist, which makes me basically a regular cardiologist, but I decided that I'm going to specialize in the rhythm of the heart. Okay. And so you see your regular cardiologist if you're having shortness of breath or if you're having chest pain, that's what they do. And my subspecialty is if your heart skips a beat, that's what I do. Right. So I'm the one that you come see. I'm the cardiologist that you come see if your heart is beating funny. While my colleagues are fantastic at dealing with chest pain and heart failure and the need for angioplasty and whatnot, I have additional subspecialty training in heart rhythm disturbances, which is why I'm part of the group, and I focus specifically on heart rhythm disturbances. So if you need a regular cardiologist, I have 6 excellent colleagues, but if your heart skips a beat, I'm the person that you come see. I'm going to share my screen. I'm going to give you a 2-for-1, and I'm going to specifically talk about AFib in a second. I'm going to go ahead and here we go. Hopefully you guys can see my screen. Yes.
Yes.
All right. Come on, PowerPoint, don't fail me. All right. So a quick story about what rhythm disturbances are, okay? So this is a nice little cartoon of what the heart looks like, okay? These are the top chambers of the heart right here, which I'm using with the mouse to show up here. And these are the bottom chambers of the heart, okay? So I deal with basically 2 different things, your heart going too slow or your heart going too fast. I'm going to deal with the slow first, okay? Your heart has an electrical system that's built into it, okay, that helps it regulate the rhythm of the heart to go appropriately according to what it is that you're doing, whether you're sitting, sleeping, walking, going to shop at the grocery store, or running from a bear, right? And bradycardia is your heart going too slow. And the most common cause of bradycardia or heart going too slow is age-related fibrosis of the system. And the symptoms of that include being tired, short of breath, decreased exercise capacity, dizziness, and sometimes passing out. I do a number of things to exclude that it's not your electrical system. Includes an EKG. I might do an event monitor of some sort of monitor that you wear. And the treatment immediately for slow heart rate is sometimes medication changes, decreasing medications, not usually adding medications, but decreasing medications, but that doesn't work. Patients usually end up with a pacemaker of some sort. That is one of the things that I do, pacemakers, okay? Now, the other thing that this is an example of a monitor. This is one of the older monitors. We don't use this anymore. The monitor now is about 80% smaller. Just a little sticker you put on the side of your chest, which is connected to a phone, which is kind of nice. Again, this is a bigger version of what's called a loop recorder, is a monitor that goes underneath your skin. The ones we have now are 10% the size of that. They're about the size of an Advil liquid gel, so they're tiny. And then this is what a pacemaker looks like. The generator sits underneath the skin. The wire goes into your heart and it stimulates your heart if you were to need one, okay? So that's a real quick whirlwind through slow heart rate. The other thing I deal with is your heart going too fast. It has many different causes, and it with differing degrees of seriousness. Your heart can be going too fast is again a problem with the electrical system of the heart. It can affect anywhere from babies. I've treated patients, although I don't anymore. The youngest patients I treat are 10 years old. Anything less than that, I send it to a pediatric electrophysiologist. But the youngest I've ever treated in my career was someone that was 6 weeks old. And the oldest I treated with the fast heart rate going too fast was about 102 years old. Again, we do similar things. We get EKGs, we give patients monitors. we do loop recorders. And again, the treatments are sometimes medications, but the majority of what I do is ablation. And we'll go in detail what an ablation is. Usually patients in which their heart goes too fast have a number of comorbid conditions, right? These include diabetes, high blood pressure, pre-existing blockages of the arteries, which is why you see my friends, the interventional cardiologists, heart failure. Common problem these days is obesity. Tobacco use is another problem. Tobacco is a definite problem in America in general. So one of the other hats that I wear is I'm the president of the American Heart Association for Northwest Indiana. I can't tell you how much time we spent on the last two, which is obesity and tobacco, how to get people to live more healthy lifestyles and to smoke less, because they really contribute a lot to, they contribute a lot to heart disease in general, not just what I deal with. And you know what, with that, I'm just gonna go to the other talk I wanna give, which is AFib, which is the crux of this issue. Now, AFib is kind of popping up everywhere if you pay attention to it, okay? And again, this is a picture of a heart I'm gonna let you take in. You know, AFib affects people of all ages and stripes of life. Those of you that are avid football watchers of the NFL, you know that one of the, pretty young guy, JJ Watt, ended up with AFib recently. And he's a football player. He's in pretty good health, He got treated for AFib and he's back on the field. So AFib is not a disease that if you happen to have it, don't think that you're unique, because a lot of people have it. I do about, in a busy week, I do up to 6 a week, and I've been ablations for AFib, and I've been doing it for now. I graduated fellowship in 2010, so almost 12 years at this point, 13 years as soon as January 1st rolls around. So it's a very common disease process. It is vastly underrecognized and vastly undertreated, partially because there's not enough electrophysiologists to go around. To give you an example, on this planet Earth, there's about 4,000 electrophysiologists, okay, on the planet. The United States has 1,500 of those. That's it, approximately, give or take, maybe 1,800. So the US has half the people on this planet that do ablations for AFib, which means we are vastly underrepresented. There's not enough of us to go around, and which is why patients end up seeing us in advanced stages of disease, okay? So we're going to talk about AFib and what that is. So again, this is what a heart looks like in real life. You've got these two top chambers, the atrium, the left and the right, and the bottom part of the heart, which is called the ventricle, okay? Blood comes into the right side of the heart, the upper right chamber, goes to the bottom right chamber, gets pumped out to the lungs, where it picks up oxygen, gets pumped back into the left upper chamber of the heart, to the bottom chamber of the heart, and then back out to your body, okay? The heart basically serves as a pump that receives blood, sends it to the lungs where it picks up oxygen, and then it gets pumped out to the rest of your body, okay? Again, to reiterate, you've got two top chambers called atrium, two bottom chambers called the ventricle, and this new yellow dot that just popped up is the brain of the heart. It talks to the real brain of your body, which is your actual brain, and it regulates the rhythm of your heart, okay? These gray things that look like triangles are actually doors. They act as like French doors in your heart. They prevent blood from going backwards and allow it to go in one direction only. And so the electrical signal in the heart starts at the top and travels to the bottom of the heart, and the blood follows, okay? So this is what it looks like in a less complicated drawing, okay? Again, this is the top two chambers, 1 and 2, bottom two chambers, 1 and 2. Again, blood comes into the top, gets pumped to the right, goes to the lung, picks up oxygen, gets put back into the left side of the heart, and it goes back out to the rest of the body. It does so in a very synchronized fashion. Now I'm just for the purposes of simplicity, I'm showing only the top part of the heart, because that's where AFib exists, okay? The sinus node here, which I've drawn here, is what usually causes the heart to beat in a synchronized manner, right? And it causes electrical impulses to start from here and move towards the rest of the heart. And then the bottom chambers of the heart pump next. And this is what causes the EKG, the thing that almost every doctor's office will do, but definitely a cardiologist's office will do, and my office will do if you come see us. What happens in AFib, the sinus node, which is up here, is no longer in charge. Other parts of your heart become active and they cause an irregular beating of the heart. And that is what is AFib, okay? And usually 90% of the time, instead of coming, so again, this is just a representation of normal, top, then bottom, okay? Top and then bottom. Now, in AFib, you see these little green burgers that just popped up? That part of your heart becomes active instead. Now, what causes that? A number of things. Age is one of them, but most commonly, it's a combination of diabetes, high blood pressure, heart failure. If you've had a heart attack in the past, that can cause it also. What happens is this part of the heart becomes more active and starts firing impulses into the heart. The best example I can give you, I give to a lot of my patients in clinic, the sinus node, which is the brain of the heart, is basically the like a conductor in an orchestra or a teacher in a classroom, okay? The sinus node is what needs to be in charge. What happens in AFib is the orchestra decides to ignore the conductor, or if you're using the classroom example, the kids decide to ignore the teacher and they're basically talking over the teacher, acting like, you know, a bunch of hooligans. And what happens in AFib is that this part of the heart becomes active and starts firing electrically, okay? So instead of having one beat, you have hundreds of extra beats, and that takes over the heart, okay? That's what AFib is. Other parts of the heart become active and start, you know, causing misfiring of the electrical system, and it starts causing the heart to beat not regularly, but fast and irregularly, because you can think about it, instead of having one teacher controlling the classroom, you have a bunch of kids yelling and screaming, and all you have is chaos. And that's what AFib is. It is chaos in the heart, okay? So again, on the left side of the screen is normal, which is, you see one arrow, right, conducting everything, and the right side of the screen is AFib. Every circle here represents a different part of the heart that's deciding to become active and ignore the main teacher or conductor of the heart, so that you get chaos instead. And people that have AFib will often tell you, I feel like my heart's just beating out of my chest. Not everyone has that feeling, but most people do, okay? Now, a normal heart at rest, which hopefully is all you guys sitting down, has a heart rate of between 60 to 100 beats a minute. In AFib, the top chambers are going significantly faster, 600 to 800 beats a minute. And that's why people feel short of breath, or they feel tired, or they feel like their heart is beating really fast, because the top chambers of the heart are in complete chaos. Palpitations, meaning the heart beating fast, is a symptom only about 20% of patients feel. The other 80% will feel tired, out of proportion of what they're doing. What I mean by that is you wake up at 8 o'clock in the morning, all you've had is eaten breakfast. You've done nothing else for the day, and you're just tired, right, by noon, which is not normal. You're tired at the end of a long day. You've worked in the yard, you've gone shopping, you played with the grandkids, depending on your age, or you're just I've done ablations in patients who are young as 40, barely started their job, and by lunch they're completely gassed. People feel short of breath without any clear cause. You don't have heart failure, but guess what? You're short of breath. People sometimes feel dizzy when their heart's beating that fast. They're not able to do as much as they could, and they think, you know what? I'm just getting old. You're not getting old. Your heart's not beating properly. Risk factors for developing AFib are all of these. Heart failure, high blood pressure. Unfortunately, females are more predisposed for AFib than males are. Age over 65, you start developing more risk factors for AFib. Diabetes. If you've had a history of a stroke or a TIA, you might have had AFib, because the number one cause of, not the number one cause, but the second most common cause of strokes and TIAs in the United States is AFib that is undiagnosed. or other vascular disease. If you have blockages of the arteries in your legs, for example, you might have AFib. We give all of these a point, okay? And this is how we determine whether you need to be on blood thinners or not if you have AFib. Why should you care about AFib? Because it can really make your quality of life worse. And if we're able to treat it, guess what? It can make your quality of life better. Also because AFib, like I said, is the second leading cause of stroke. Well, it's now the second. It used to be the third when I made this slide, but sorry, no, it's the second leading cause of stroke, but the stroke is the third leading cause of death in the United States. Stroke still remains the leading cause of serious long-term disability in the United States at any age. 25% of strokes happen in patients less than 65 years of age, so it's not a disease of older patients. I'm talking about stroke here. On average, approximately every minute, someone has a stroke. That's a lot of people, right? And atrial fibrillation is an independent risk factor. If you have AFib, or if you've had AFib, you're at increased risk of stroke, and you should be considered for some sort of blood thinner. And AFib, especially now, if you watch enough TV, you'll hear something about AFib. It's the most common rhythm problem in the world, and it's often overlooked. As our patient population is aging and people are getting older, you go to your doc, and doctors are under increasing pressure, not just from the government, also by insurance companies, to see more and more patients because there's just more of them. So sometimes this sometimes gets overlooked because you've got other problems going on: diabetes, high blood pressure, heart failure, so on and so forth. And again, how does stroke occur in atrial fibrillation? What happens when your heart is beating irregularly, right? Clots can form inside the heart. And if a clot forms inside the heart, the first place it goes is the brain. I love to, because I'm a cardiologist, I'm biased. I think the heart is the most important organ in the body. It kind of is. But, close second, if not tied for first, is the brain, okay? And the evidence of that is that once blood leaves the heart, one of the first places it goes is your brain. So if you have a clot inside the heart because of AFib, guess where it's going to go first? It's going to go to your brain, okay? Now, there's two schools of thought when it comes to treatment of AFib, okay? I'm going to say door one or bucket one is, you know what? Your heart's going fast. We're not going to fix the AFib. We're just going to slow it down. We're going to give you medications so your heart's not beating so fast. That's one way of doing it, right? And for the first 10 years of this century, from 2000 to 2010, that was pretty much how things were done majority of the time. But 2010 onwards, there is undeniable evidence, more and more over time, that just controlling the rate of the heart is not enough. What you got to do is fix the problem, what we call rhythm control, okay? And that's where I come in, because honestly speaking, I'm the only one, not me, but electrophysiologists in general are the only cardiologists that are trained to do all of it, and that's why, I'm seeing more patients, and I really impress upon my patients, when I do these talks, that, if you come see me as an electrophysiologist, or if you come see another electrophysiologist, we are not in the business, or nor do we desire to replace your existing cardiologist. All right, you still need your regular cardiologist to deal with high blood pressure and cholesterol, and if you have heart failure, and if you have blockage in your arteries. I'm not there to interfere with that. I'm just here to take care of my subspecialty, which is rhythm control. And if you come see me, it is zero disrespect, or nor are you offending your cardiologists, especially the ones in my group, because I don't interfere with what they do. They do what they do, I do what I do, and we work together as a team. But regardless of what you do, we need to talk about blood thinners. Whether you decide to control, to slow the heart down or fix it, blood thinners are important because stroke is an important complication. Now, in the blue are all the drugs that different doctors might use to slow the heart rate down, okay? And the red are the drugs that I would use to try and convert the patient from AFib into normal rhythm. Now, I will tell you that medications, even number 4 here, which is amiodarone, probably the most commonly used drug, because it is one of the most effective drugs. Drugs are only about 40–50% effective. They're not very effective, and they make patients feel ill. So, which is why I often will use ablation to deal with AFib, and not use drugs as much, because ablation just tends to do better at this point in time. Now, how do we do this? Well, I run a catheter into your heart. This is a cartoon of a character. It's a little blue, looks like a magician's wand. What I do is I go into the heart, I locate the parts of the heart that are causing the AFib, and I make small burns, okay? These burns are about as big as the tip of a ballpoint pen. I make a bunch of them, right? Up to 50 in a patient, and we locate the parts of the heart that are causing it, usually these veins that enter the heart, and we burn those little by little until we have made that part of the heart that's causing the AFib inactive. It doesn't affect the pumping function of your heart. It just prevents the electrical misfiring of the heart. This is what it looks like in real life, okay? That big little white thing is my thumb, all right, to give you a scale. And that's how big the ablation catheter is. It's not very big, all right? And people always ask, how do you do it? It's almost impossible to explain how I do it, but this is someone's heart before the ablation on the upper left, and the bottom right, sorry, is after the ablation. All the red, those little red dots you see, are the places we burned to get the patient out of AFib. The number of spots we burn varies from person to person. There's no set number. The procedure itself depends on the person. How many burns you make can last 30 minutes to an hour to an hour and a half. Because I get patients usually after they've been in AFib for a number of years, which is not ideal, the procedures can last longer. Ideally, I like to get patients once they've had their first or second occurrence of AFib and not wait until they've been cardioverted or shocked 5–10 times or been on medications. I'm trying to convince, and my cardiologists at Methodist that I work with are pretty good about this. They get patients in to see me pretty quickly, but not all of my patients come from my Methodist cardiologists. And never feel shy to seek out an electrophysiologist, even if you have a cardiologist, because like I said, most of us electricians, we don't really want to interfere with your cardiologist. We just want to take care of the electrical problems. So the treatment of AFib, who can offer the complete list of services? It's people that are electrophysiologists. And again, I can speak for myself. I don't want your cardiologist's job because it's too much work. And we work better together instead of against each other. And I've built a pretty good relationship with my cardiologist. We work together. They take care of I call them the plumbing issues. I take care of the electrical issues. Okay. I'm going to take a quick break there and do a quick open mic for questions that you guys might have. Hopefully I've stopped sharing my screen. And yeah, whoever's moderating, please start moderating. Whoever wants to ask questions, please. No questions.
Well, I have a question about, can allergies and asthma affect the heart? And is that one of the causes of possible AFib?
No, sleep apnea can contribute. Okay. If a patient is overweight and they have sleep apnea, that can definitely contribute. That being said, getting rid of the sleep apnea by losing the weight or by getting a CPAP machine won't get rid of your AFib. It'll decrease it, okay, but it won't get rid of it.
Okay. But as of now, allergies and asthma do not seem to affect.
No.
Okay, good. All right. That's my question.
No. If someone has it, they should definitely get it treated, but it's not going to cause it, if that's the question you're asking.
Okay. Can chemo cause heart problems?
In general, yes. A lot of chemotherapy can cause heart failure.
Okay,
Specifically, chemotherapy for breast cancer can cause heart failure, which is why if your oncologist is going to start you on medication that can potentially cause heart failure,
right.
they will have you see a cardiologist to assess, and that's what my plumber colleagues will take care of for you.
But doesn't it depend on the type of, because I had chemo.
Yep.
It's 8 years out.
Uh-huh.
I was told that the chemo they used on me were 2 chemicals that would not affect the heart.
Okay.
So there are chemos that don't affect the heart?
Yeah.
Okay.
Yeah. You got all stripes of chemotherapy, those
Okay.
that do and don't affect the heart.
All right, good.
Hello. One of the things that I'm concerned about, it may not be serious enough to seek you, but if you're having like the tiredness, you walk quickly, let's say in the mall, and you have to kind of stop to I guess catch your breath or whatever. Are these signs of something other than maybe overweight or I'm not sure.
So here's the thing: if you think you need an electrophysiologist, come see us. I mean, it's like don't make the decision on your own, right? To not to go see someone, right? It's, you know, I can initiate the workup. If it's not electrical, I can send you, at least you have that part of the equation solved, right? Then you can go to someone else to figure that out. I mean, shortness of breath or fatigue is it could be anything. It could be your heart, it could be your lungs, it could be your, endocrine system. It's a very vague shotgun sort of complaint. So if you're feeling that way, definitely get it worked up.
Okay,
Right.
and come to your office or to someone that's an electrical person.
Yeah, I mean, yeah,
Right.
absolutely. Absolutely. We can start the workup. If it's not us, then there's nothing to do. We can move you on to the next person. Shortness of breath is like I said, it's a pretty wide complaint.
Mm-hmm.
It could be a number of things.
Okay, thank you.
Uh-huh.
Good afternoon. I have a question about the heart. Sometimes at rest, it flutters like a fish would out of water.
Yep.
Is that
It could be.
AFib?
That's one of the things my patients complain about when they say they have AFib. My heart just feels like a fish out of water. And again, it could be, but it could be nothing. And I won't know until I do the appropriate monitoring.
Okay. All right. Thank you. Because
Uh-huh.
I've worn the halters.
Unfortunately, halters are not the best monitor to wear because they only last 24 hours, right?
Okay. Yeah.
And,
Yes.
and the majority of halters out there are pretty big, clunky little things that you have to wear all day, and you can't take it off, and so on and so forth. My clinic, we have a 30-day monitor that literally is about that big. It sticks on your chest, and and you can take it off whenever you want to take a shower. It's not restrictive. So, like I said, when it comes to rhythm problems, I mean, we're the best that's really suited because we will have technology that your regular docs won't have.
Right.
And it's because that's what we do. That's what I do for a living. That's all I do.
Thank you so much.
Yeah.
So how does taking blood thinners help with avoiding AFib?
It doesn't.
Oh,
It
okay.
just prevents strokes.
Okay, that's what stroke. So how does it prevent strokes?
It thins out your blood.
And that causes it to not.
It causes it not to develop a clot, right?
Okay, the clots.
Yeah.
Okay, gotcha.
Yeah. Clots are prevented by blood thinners. It won't do anything for the AFib, but if you have AFib, it's going to prevent you from having a stroke. So when you have AFib, you've got two separate problems. Problem number one is the potential to have a stroke. Problem number two is the AFib, which is the symptoms of AFib, right? So The blood thinner will do nothing to control the rhythm of your heart, but it will prevent you from having a stroke.
Thanks.
Yeah, no problem.
I have two questions.
Sure.
First of all, how do you determine where to do the ablations? And secondly, how much risk is there in having an ablation?
The how I do it is very hard to explain. It's hard for me to explain to other cardiologists. So it's really hard to break it down. We have to test the top chambers of your heart extensively, right? And that's hard to explain, but we look at the different chambers of your heart to determine which part to burn. How risky is it? No matter where you go in the United States, okay? You can, get your ablation done at Methodist. You can go to Northwestern. The risk is the same, is about less than 1% of major complications, okay? My personal complication rate, I've been doing this since 2010. I've never had a patient die or have a stroke as a result. And I've told you that I'm very blessed. I do about, at the most, 6 a week. So 13 years, it's a lot. And I've been very blessed not to have any complications. So my personal batting average is 0, but nationally it's about 1%, at the most 2% of major complications. There's those of you that are listening, I'm trying to see if I can put it up on the screen. Give me a second, there's a really good website. I'm gonna pull it up and then share the screen with you guys. Okay, give me a second. Let me share my screen. Hopefully you guys are watching. Yes, you guys can see it?
Yes.
Okay, so the website is stopafib.org, okay? But it's preceded by a www. It says www.stopafib.org. This is a patient-created website, okay? And it's run by patients, created by patients. I have 0 input into this, but this is a great resource for patients, about, patients who've had ablations and so on and so forth. All right, I'm going to go back. There we go. Hope you guys got that. So it's www.stopafib.org. Okay. And was there another question that I missed, sir, that I didn't answer? One was like.
No, that was the 2 questions I had. Thank you very much.
All right, sir.
Doctor, thank you for doing this, and Methodist for doing this. It's always helpful for the community to get this information into the community. My question is, with Medicare, if Medicare is our primary insurance carrier, is there any reason or need to go through our primary care for a referral to you, or can we, if we're manifesting one or more of these symptoms that you identified or have complications like diabetes, can we just make an appointment with you directly?
Absolutely.
Thanks.
You don't need a referral. But let me, since you guys are all savvy and you're on, I'm going to share my screen one more time. I need your help. Okay. This is why I need your help. As you know, Methodist is a safety net hospital. A lot of the hospitals surrounding us don't necessarily take Medicare and Medicaid, right? They only take commercial insurance. Methodist is probably the only hospital in the area that we don't turn anyone away, right? Regardless of their need. And we get federal and state funding to take care of patients of all stripes. And we're happy to do that. And one of the reasons I love working at Methodist is we don't turn anyone away based on insurance, okay? Now, why that's important is because CMS is planning to cut reimbursement for Medicaid, Medicare patients, which means that we're going to be limited in our ability to help patients out who have Medicare and Medicaid. So I'm going to share my screen one more time. And what I'm going to show you this time is a website. Again, it's preceded by www. It's called saveablation.org. Okay. And I'm just gonna, yeah, so it's right here is the website, Save Ablation. I've circled it. It's www.save. It's a automated site. All you got to go is go in there, go to this website, click on, you know, what do you call it? It says down here, tell Congress to save ablation. You just click on it, give it your zip code, and there's a pre-printed letter you can send to, I think, from Maryville is Mervan. And wherever your zip code is, because you know there's not enough of us to do ablations in general United States, and CMS is going to be taking my ability away to treat patients that are Medicare, Medicaid, which is a real travesty, I think. And I would love to continue serving the local population, but I if you guys can do the simple thing of helping me, I would really appreciate it. Again, it's www.saveablation.org, one word. And Heart Rhythm Society is the society that governs what we do, what I do. It's the group of people that this is a society that helps us educate ourselves, do more research, help out patients, so on and so forth. So if you guys can spend literally 60 seconds to do that, I'd really appreciate it.
Will do.
Follow up to that particular statement that you just made, Doctor. Can you briefly give some information about why Medicare has a bias against ablation?
So
I mean, I know that they're not.
So the problem is this, and it goes into a bigger social problem that I'm sure you know about, and that we can't really go into the depth of, is the government puts aside, I don't know, 5%, some small percentage for healthcare, right? And that percentage is fixed. So every year they decide to redistribute the pie, right? We're going to give more to someone, we're going to give less to someone, right? And electrophysiologists are easy targets because I told you at the beginning, there's only 1,500 of us in the country that do what I do, right? So as it is, we're just overloaded the amount of work we have, and so we're easy targets. You target the people that have the least numbers to defend themselves, is what it is. And we spend the other 95% of the budget on, I don't know, the majority of it goes to military spending so we can fight, I guess, Canada and Mexico because they're attacking us all the time. That's I'm being facetious, of course, but that's the problem. Is we'd rather spend money on anything else but healthcare. And we're lobbying to try and save it, but the voice of the patient, especially patients in areas that are served by Medicare, Medicaid, is more powerful than a simple doctor. Does that answer your question?
Yes.
Yeah, I'm sure they'll go after cardiac surgery next or someone else, but we happen to be on the menu for next year.
Check chat for a question.
Uh-huh.
Check the chat for a question.
Why is it not letting me get into it? The answer is it could be, but there's no way to know unless you have a monitor on at the time that you have your cough. And that's why I give out a lot of monitors to my patients, because unless I have an EKG at the time of your symptoms, there's only one other person who knows that knows what's going on in your heart, and that's God. So the monitor is the next best solution. That's why I usually give patients monitors for whatever symptom they're having, and that way we can, figure out what it is. Anything else, guys? But yeah, if you need to find us, it's 219-738-5330. That's 738-5330. That's the clinic number. You don't really need a referral. And again, like I said, I'm not in the business of separating you from your primary care doctor or your primary cardiologist. I'm busy enough just taking care of AFib and all the other heart rhythm problems. So I focus on just that, and that's it. And usually work on the same team and never against your primary care doctor or cardiologist. Okay. Any other burning questions? No? All right, does this bring it to a close then? I'm hoping my moderator is here somewhere.
Yes, I'm still here, doctor.
Okay, all right.
Yes.
All right.
All righty. Are we
All right,
done?
guys.
Okay.
Yeah.
Sounds good.
If you need us, call us. But yeah, no, I'm really happy to be at Methodist because we have some of the best equipment. Our hospital administration has been fantastic to get us the most up-to-date technology. And I'm happy to serve this population because before I got here 5 years ago, there wasn't no option. You just had AFib and you lived with it until it got you. AFib is just part of what I do. Pacemakers, defibrillators, other rhythm problems. I mean, they were completely unserved, not underserved, but unserved, and that was just really bad. So don't be shy, okay?
Isn't Methodist somewhat of a research hospital?
No, not this. I mean, I do research, but it's not like a university hospital. No.
Okay.
We are affiliated with University of Chicago for different clinical services, specifically cardiac surgery.
Okay.
Again, I do research on my own, but it's not part of any university. It's just I'm curious.
You don't get the latest, because I know for mammograms, it was the one leading in this whole area, including Chicago, with the 3D mammogram.
Yeah, no, that's probably because we had some good doctors that are willing to push the envelope, and the administration got us the toys that we needed.
Okay.
That's what happened for EP anyway. When I got here, we had nothing. We had a system to do my ablations that was the oldest in the state, and
Wow.
within a couple of months, the hospital was kind enough. I started here in 2017. By the end of 2018, they built me a brand new operating room. We've been using it ever since, and it's been really good.
Glad to hear. All right.
So if we're ahead, it's because our administration has helped us.
Thank you so much. It was very informative today.
Very good, guys. I am going to take my leave. You guys have a fantastic day, and I'll see you again someday, either in clinic or another one of these things.
Thank you, doctor.
All right, take care. Bye-bye.
Bye-bye.